GY5s, and I'm going to be talking today about posterior acetabular wall fractures. I'm looking for Dr. Jim Goulet, Aaron Purdue, and Mark Hake. So we'll start off with a case. 17-year-old teenager who sustained a fracture dislocation of his right hip when he was tackled while playing football. No past medical or surgical history. Here is his initial imaging. You can see a posterior fracture dislocation of the right hip. I don't know how well it projects on the monitor, but there's a small flex from the posterior acetabular wall. And then inferior to the femoral head, you can see a small piece of bone. So here's an outline for today's talk. I have a lot to talk about, so I'll get started. So, posterior wall acetabular fractures are the most common. They represent about 25% in the isolated form, and they're even more with the associated. They're also the most likely acetabular fracture to be treated in the community, and I think that's because of treating surgeons' familiarity with the posterior approach. So this is kind of why I picked this talk today. So to begin with evaluation of acetabular fracture, you got to have good x-rays. So on an AP x-ray, there's multiple lines we can look at. You got the iliopectineal for the anterior column, ilioischial posterior column. You can see the anterior and posterior walls. You have the teardrop and the roof. You need to be evaluated on all AP pelvises. You also have Shenton's line down below, and that will be disrupted in any type of dislocation. So when you evaluate acetabular fractures, you need to get Judet views. These are 45 degrees off of the coronal. This is an example of an obturator oblique. This will show us the anterior column and the posterior wall. Here's an example of an iliac oblique. This shows the posterior column, as you see coming in the back, and then the anterior wall. So Luttrell and Judet kind of revolutionized acetabular fractures, and they divided them into elementary and associated fractures. The posterior wall is one of the elementary fractures. And don't be deceived, the elementary fractures don't necessarily do better than the associated fractures. The OTA also has a classification. I did not know it until a couple of days ago. But it actually is pretty useful because it breaks down the posterior wall acetabular fracture from one fragment, multi-fragment, or marginal impaction. And for research purposes, as you get more fragments and more marginal impaction, these do worse. So it's good to be able to stratify them like that rather than just lumping them all into one category. Marginal impaction is when the subchondral bone or when the articular cartilage gets impacted into the subchondral cancellous bone. And if you don't reduce that at the time of surgery, the person's hip's going to have problems. So initial workup. These can be high energy from motor vehicle accidents, but they can also be low energy like in ours and a kid getting tackled in football. But ATLS, protocols need to be followed. A good AP pelvis on initial evaluation, history and physical, a secondary survey looking for additional injuries. The position of the leg can tell you where you might expect to see the posterior wall acetabular fracture. As the leg is more extended, you expect to see a more superior fracture pattern. As it becomes more flexed, you expect to see more inferior fracture pattern. If it's in a neutral to a slight adducted position, you'd expect to see just an isolated posterior wall. Some things you don't want to miss down in the ED when you're first evaluating them. Sciatic nerve injuries can occur. I saw in the literature it's from 10 to 30%. It's probably closer to the 10 to 15. These don't necessarily always come back. About 50% of them do. If it's a tibial nerve distribution, those are more likely. The perineals, are a little less likely. I also want to make sure you don't miss a ligamentous knee injury, a big swollen knee. If the person's knee is flexed and they hit the dashboard, they can get a PCL injury. Morale ovale lesions. These are basically an internal degloving of the skin between the skin and the subcutaneous tissue. Why is this important? If you operate through that, you're probably going to have a much higher risk of infection. So you need to recognize that early and adjust your operative plans accordingly. And obviously, if there's a femoral neck or head fractures, you want to treat those appropriately. So initial workup. So the older literature talked about a dislocation of upwards to 85%. Now, these don't always come in dislocated. Sometimes they reduce on the ambulance ride over, but it's very important that if they are dislocated, that you get them reduced as quickly as possible. There's been a lot of studies from back in the 50s, and they kind of found in their patient population that less than 12 hours was the magic time, and it's been confirmed by more recent results in the 2000s. Some people have talked about a 6-hour time window, but the issue with that is the amount of people in the 6-hour to 12-hour group is pretty small, so it's not really powered to pick that up. But obviously, the earlier you can get in, the less chance for osteonecrosis later on. So, fracture dislocation should have a CT scan performed after a reduction to look for loose bodies and to see the fracture morphology better as it comes back down. You really want to, when you first find out about these, try to avoid them getting the CT of the pelvis before you get the hip reduced, just to try to avoid a little extra radiation. I think CT scans have improved from where I got these numbers, but at one time it was 3 years of background radiation compared to 3 hours for an X-ray of an extremity. That's a lot of radiation. So, traction. Should all of these get traction? Well, if it's unstable, it should get traction because you want to keep it from dislocating out, keep the head under the articular dome. You also should put in traction if there's an interarticular loose body that's located in the weight-bearing dome, because if you don't, the head's basically going to migrate superior and crush that into the articular cartilage, and that's bad. If you don't put them in a traction, you can always put them in a knee immobilizer. There's a study that shows that when you have the knee extended in a knee immobilizer, the hip flexion goes from 45 to 95 degrees. So 95 degrees without, 45 with. So emergent indications for surgery: irreducible hip, unstable hip with traction, associated femoral neck fractures, and open posterior wall fractures. So now let's talk about the surgery. So your surgical goals are to get a joint that's congruent and stable. So all loose bodies are not created equally. If you have one in the acetabular fossa, that could likely be an avulsion of the ligamentum, and that's not something that you have to go off of. Also, there's been a lot of talk on CT-based classifications, and right now, in the last, I think, couple of years, the shift has been moving away from those and moving towards using dynamic stress under fluoroscopy and general anesthesia to evaluate if these are stable or not. This second article I put on here talks about these superior posterior wall acetabular fractures, and if you use that, a 20% posterior wall fracture, they had even 23% of those were unstable in these more superior posterior wall fractures. So if you just treat them based on how big the wall piece looks, you're probably going to send out some people that are unstable, and that can be bad. Now, in the study on the top, the ones that they treated and were found to be stable, they had good outcomes and healed well. How do you examine someone under fluoroscopy? The first thing you do is you flex them up to 90 degrees and you apply your full body weight and axial load, and you check it under AP and an obturator oblique view. The goal is not to dislocate the hip. That's bad. You want to just sublux it. If you sublux it, it's unstable. You need to fix it. If it's still stable after just flexing it and applying that axial load, you can apply a 20-degree internal and adduction to try to further put the hip under stress. If it's stable, you can treat it non-operatively. So timing. So the original thought was you needed to wait a little while on these, but this came out of shock trauma, and it showed that you can operate on these in less than 24 hours and really not have any increase in EBL. So you can get to them quickly. So surgical approaches. So the Kocher-Langenbach approach, I think this is kind of why it's done in the community a little more often, is because people have experience with the posterior approach to the hip and think the Kocher is just a more extensive approach to this. That's not exactly the case. We'll talk a little bit about that here. So you can see here on just the surface outlines of the skin incision, it does appear just to be a little more extensive. On the left is the Kocher, and you can see it at a little more acute angle at the tip of the greater trochanter. So really, once you get through the IT band, that's about where the similarities end. So in a posterior hip, we don't expose the sciatic nerve. In a Kocher-Langenbach, you always have to expose it and visualize it and protect it the whole time, because you're working essentially right under it. So you'd be asking for trouble if you didn't do that. You can do the Coker approach in a prone or lateral position. It really doesn't make a difference for these posterior walls. It's more surgeon's preference. When you have more, you're associated a transverse acetabular fracture with a posterior wall. The lateral can cause you to get some malreduction. The other issue is when you get in here, the tissue planes aren't normal. They've sustained a very significant trauma. So you'll see dead muscle of the external rotators, the gemelli, loop minimus, and this dead muscle has to be removed. If you leave it there, you're just going to create a bunch of heterotopic ossification, which is bad for hip motion. You also really have to respect the capsule. The capsule is what's holding on these little pieces that we see on the CT scan. And if you take the capsule off of the pieces, you'll take off the blood supply, and these pieces will die. Finally, because we're not cutting off the head, we have to respect the blood supply in the femoral head, and that's from the medial femoral circumflex artery. To do this, we cut under direct visualization the piriformis and obturator internus tendons 1.5 centimeters from their origin. If you cut them right off from their insertion, you will probably get the blood supply. We also don't go in the quadratus femoris at all. So here's a picture. Some of these patients can be obese, but they all have to get operated on if they're unstable. And this is a picture from a recent article published by Dr. Mark Seeley, and it shows the danger zone of the medial femoral circumflex artery there, and you can see right next to the insertion of those tendons I just talked about. Here's some other approaches. The Gibson incision is popular in St. Louis. Essentially, it goes anterior to the glute max. It's for more superior anterior fractures of the posterior wall, trying to avoid putting as much stretch on the superior gluteal artery that happens if you're having to go significantly proximal. Other things you can do is take off a little bit of the glute medius if you need to help that exposure, and just do the normal Coker approach. If you have a femoral head fracture that you want to fix in addition to a posterior wall, you can do a Gons trochanteric flip osteotomy and surgical hip dislocation. And you can get to the posterior wall through that. So the most important thing is that you reduce the fracture. You got to respect the capsular attachments like I talked about, because if you don't, you will devascularize them and they won't heal. And you got to get all the loose bodies removed from the joint. So let's talk a little bit about plating. So this is a pelvic reconstruction plate. It's a 7-hole plate. The important things about the plate is you want to make sure you under-contour it a little bit. When you under-contour the plate, it pushes the fracture that you reduced back. If you over-contour it, it won't hold the fracture in place, and the fracture will spin out, and you'll be unhappy with your results. The next thing is the 6th hole here distally is probably the most important screw hole that you place, and it's you can see it has more of an acute angle. So that's right where the ischium tuberosity kind of flares out. And if you don't get that angle to match, the plate won't sit properly on the bone, and you won't be able to reduce your fracture. So essentially, this plate is just buttressing the bone back. So spring plates are another thing that are used for these really peripheral fractures. The way you make a spring plate is you take a 1/3 tubular plate, a 3-hole, you flatten it out, you over-contour it like that, and then you take out on the most lateral hole, you cut the plate so you have 2 tines going out. You place the tines right on the rim but not on the labrum. And then it's very important how you place your screws. The yellow one in the middle, that one goes first, so that compresses the plate down and lets the plate work. The second one, the red one, that makes sure your plate doesn't work like doesn't move back and forth. So if you don't put that one in, you're going to have problems. And then you can put your plate on over top, like we showed in the previous example. So let's talk a little bit about outcomes. So these patients take about 2 years to get to their maximum outcome, but they still don't get back to their quality of life norms. So Joel Mata has done a lot of work on these, and he published his series on 810 patients treated with acetabular fractures. And I want to just touch on some of the main points because they bring up some interesting things in regards to posterior walls. So in his group, he looked at the 20-year survival of these 2 to 20-year survival of these acetabular fractures, and the marker he was looking at is did they get a total hip, so they contacted all these patients. And he had some very interesting findings, and I think it's good to keep in mind if you ever think about fixing posterior wall fractures and you don't regularly fix them. So indication for a negative result of an acetabular fracture is a posterior wall fracture. So He graded his reductions, and he graded them himself, but on his x-rays, he had 93% what he considered perfect reductions. And even with that, he had the posterior walls did worse than most of the other acetabular fractures. They had a 76% 20-year survival. So negative risk factor for posterior wall fracture, even in the best of hands. So non-anatomical fracture reduction, that's pretty obvious. Increasing age. Anterior hip dislocation or a post-operative incongruence of the acetabular roof, so if they maybe left a loose body or didn't reduce it. Involvement of the posterior acetabular wall. Femoral head cartilage lesion, that's also pretty intuitive. And utilization of the iliofemoral approach. The iliofemoral approach, I think, has gone out of favor. It hasn't had really good results, so there's not a lot of indication for that today. So here's the 20-year survival curve. And in red, I traced out where the posterior wall fractures fit. And you can see it fit on the bottom of the survival curve. So it's something to keep in mind if you ever think about fixing these, and you don't do it regularly, that even in the best hands, you can expect, worse outcomes in posterior wall fractures compared to even other acetabular fractures. So complications. So 10% of patients do get heterotopic ossification. I talked about it earlier. It comes from the glute minimus. You got to take that out. Dead muscle turns into bone, and 10% of it can interfere with the hip motion. Osteonecrosis of the femoral head, associated with time of reduction. Don't forget, DVTs do happen, and pulmonary embolisms are hopefully a very rare event. Nerve injuries. Letronell quoted his series less than 1%. Letronell basically embedded fixation acetabular fractures. Some of the more recent literature says rates between 2 and 10, and the Coker approach is associated with a higher risk of iatrogenic nerve injury. And finally, I'm just going to touch on arthroplasty because I think it does have a role in these fractures, especially in the older patients. So a patient that's greater than 55 years of old with greater than 3 fragments or marginal impaction, they're probably going to do really bad with a posterior wall ORF, and will probably benefit from a acute versus delayed primary arthroplasty. They've done some studies on these. This is just a very small series looking at people that are converted from ORF to arthroplasty, and as you would expect, the patients that were converted from an ORF of a acetabular fracture did worse than patients that just had a primary total hip for their Harris hip scores. Finally, this is an interesting study out of Canada by the Canadian group that publishes all the time. They looked about 100 patients retrospectively over a 10-15 year period, and they matched them to controls. And they found that these patients that are treated with a total hip after a fixed acetabular fracture have significantly increased risk compared to just a primary arthroplasty. They had a 9% risk of infection, a 7% risk of dislocation, and a higher risk of heterotopic bone formation. So it's something to keep in mind, with the way the billing and bundle care is going. If you fix a lot of these, you would expect to have higher complications than if you're just doing primary total hips. And so finally, regards to arthroplasty, I think we still need better studies. I was trying to look in the registry data last night, and I couldn't see anything about acetabular fractures. And part of that is, they're hard fracture to classify. And if you don't classify them correctly and grade their severity correctly, your data is going to kind of be garbage. So I think, they need more prospective studies, and looking at, some of these older people, and you do an acute versus delayed, what type of implant do you use, and what type of cup do you use. But I think there's definitely a room there for more research. So let's get back to our patient. So he was reduced, and he was felt to be stable, so he was just placed in a knee immobilizer. Hopefully you can make out there's a small little piece of bone there. That's a flex on the posterior acetabular wall. And here's the CT scan. So you can see this piece of the wall is kind of, kind of cattywampus turned around. And then here in the front, you can see this little, this is the donor site of a femoral head lesion. It's infrafoveal. And there's a small fragment from that, just more distal. So the decision was made. Sorry, I forgot to point out. Here you can also see a little loose body in the joint, and that was very important. We need to make sure we go after that and get that out of there. It's going to cause problems if we don't. So because of the loose body and his age, and we decided to go ahead and fix him. So when we got in there, there was significant damage to his gemelli, minimus muscles. They were very damaged, and we kind of expected that. His labrum was also torn, so we resected some of that, and then we suture anchored to place it back as close to its anatomic position as we could. We then cleaned the fracture up and placed a peripheral 7-hole plate like I described previously. So take-home point for this talk, I think, is even with perfect reductions in the best hands, posterior wall fractures are significant negative risk factors for hip survival. So I think if it's a fracture that if you're not experienced fixing, probably should avoid and leave it up to people that are doing a higher volume. So I'm happy to take any questions and hear my references. Thank you.
That was a great job, Todd. Great review of that topic. This patient was a football player, and usually our sports accident fracture goes to Mark 8. Stepped in and his head, and hopefully we'll have him spit it out from his needed for his patient. I think you kind of hit the nail on the head, and what I talked about the MLS a few years ago is what accident fracture shouldn't be really treated in the community, and I would submit to you that these are the ones that shouldn't be. Well, probably all of them, to be honest, but these do have the worst outcomes, especially when you get into marginal fracture. So interesting data that talks about time of dislocation reduction doesn't matter. I had a hard time believing that, so I think there's literature on both sides of